Hello, and welcome to today's Parkinson's Foundation program, Mind, Mood, and Motion. I'm Melody McLaughlin, Senior Community Program Manager for the New England and Mid-Atlantic chapters of the Parkinson's Foundation. I am so thrilled to be joining you today for this very special program. For those of you who are newer to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's, the people who love them, and all of those who are working to end the disease. And albeit virtual, we're absolutely thrilled to be here for our very first community-based education program for the Mid-Atlantic chapter. We warmly welcome those within our Mid-Atlantic region, but also the many of you joining from across the country as well as abroad. It's with our presence in communities around the globe that we believe in a promise of a cure and a better life today for those impacted by Parkinson's. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone for today, understanding Parkinson's through research for tomorrow, and educating and empowering the Parkinson's community for us all. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, our hospital safety kit called Aware and Care, our newly diagnosed kit, and of course, our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson's specialists. And then on the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to especially highlight PD Generation, a national initiative that offers genetic testing and counseling at no cost for people with Parkinson's disease. We're excited to announce that PD Gene has launched its next step, a genetic test at home. To learn more, visit parkinson.org/PDGeneration. So how are we connecting with our communities? Your being here with us is a prime example of that. It's really through our Centers of Excellence network, our local PD experts like today's speaker, volunteers, advocates, and staff across the whole country that we bring people together to educate and empower those impacted by Parkinson's. We also connect with our communities through our nationwide Moving Day events. Since 2011, our Moving Day walks have raised more than $30.8 million to support research, our centers of excellence, and provide educational resources and programs across the country. We hope that you'll join us for our Moving Day Baltimore on May 1st, or maybe you're in the DC area for Moving Day DC on May 15th for our drive-through rewards and resource pickup, as well as our virtual event on May 22nd. To learn more, please visit Moving Day DC or movingdaybaltimore.org. And always looking for ways to keep the PD community connected, the Parkinson's Foundation has been providing weekly educational and wellness programs in a virtual format through PD Health at Home series. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. And today's program was made possible by the support of our sponsors. Today, we thank Kiowa Kieran. We invite you to learn about our program sponsors by visiting our chapter supporters webpage at parkinson.org/midatlantic/chapter-supporters. And with that, I'm now delighted to introduce today's speaker, Dr. Gregory Pontone. Dr. Pontone is Associate Professor and Director of the Parkinson's Disease Neuropsychiatry Clinic in the Departments of Psychiatry and Neurology at Johns Hopkins University School of Medicine in Baltimore, Maryland. After completing a medicine internship and residency training in psychiatry at Johns Hopkins, Dr. Pontone completed a 2-year fellowship in geriatric psychiatry and movement disorders focusing on Parkinson's disease through the clinical research program at the Morris K. Udall Parkinson's Research Center at Johns Hopkins. Please join me in welcoming today's speaker, Dr. Pontone.
Hello. I'm going to go ahead and share my screen with you guys here. Hopefully, I'm a gremlin, so anything might happen. There we go. So today I want to talk to you a little bit about how Parkinson's might change your ability to think and behave in the ways that you're accustomed to. So the objectives today are really to understand the types of cognitive changes that might occur in people with Parkinson's, and everybody's experience with the disease is different. And so, just because I mentioned something here today doesn't mean that it'll necessarily be something that everyone with Parkinson's experiences. Hopefully today we'll have a little better understanding of depression, anxiety, and apathy, and some of the mood difficulties that are associated with Parkinson's disease. And then we want to explore some of the recent research concerning the effects of both cognitive training and physical exercise on cognitive decline in Parkinson's. I think there's some hopeful messaging there. And then finally, I want to talk about some practical strategies that'll help improve day-to-day life when you're experiencing cognitive decline, and provide you some tools to help your well-being in general. Okay, so one of the first types of changes that many people with Parkinson's disease will experience is what we call executive dysfunction. And it's pretty much everything you'd expect an executive of a company to do. You know, it's organizing, sequencing, planning. And when I say early, I mean really early in the disease process. Sometimes even before people are diagnosed, you know, the disease is affecting the biology of the individual. And in what we call prodromal cases, they've detected executive dysfunction in some people. Memory impairment may also occur in a subset of people with Parkinson's. Again, not everyone, but some people might experience some memory impairment. So we'll talk a little bit about that. Slowed processing speed is also very common. Just like the body slows down, sometimes the thinking process slows a bit. And then finally, diminished attention and what we call cognitive fluctuations can occur. And I'll talk a little bit more about what those are in a minute. So executive dysfunction, as I mentioned, is difficulty with organizing, sequencing, and planning. And I think probably the best way to give an example of what this might look like in day-to-day life is to talk about what I call Laura's vignette. And so here's what Laura had hoped to do. She said, today's goal was to finish writing the holiday cards, put them in stamped envelopes, and mail them. But after I wake, the first thing I have to do is take my medications. I put the medications on the table near my bed in a little paper cup before I go to sleep each night. But I forgot water. So I go to the kitchen for water and notice that my mulch came. So I start spreading the mulch until I'm interrupted by a phone call from Karen. And I decided it'd be easier to talk with Karen over lunch. So we go out to lunch. After lunch, I find the envelopes in the closet. So she hasn't forgotten. She comes back to the, major goal of writing the cards. But she finds she only has 3 of these envelopes left. So she goes to the store, buys more envelopes. But when she comes home to write the first letter and put it in an envelope, she finds out she has no stamps. Now, the first thing I would say is we've all had days like this. And so, one event like this doesn't mean that you have some profound degree of executive dysfunction, but you can clearly see the inefficiency of the day. And often what happens is in people who are experiencing executive dysfunction, they notice that either they seem to be busy all day but get very little done, or at the end of the day, they've started many projects but left most, if not all of them, unfinished. And this looks a little bit like what we see in attention deficit disorder in children. And it probably has origins in the same part of the brain, the frontal striatal parts of the brain, which are 2 of the main places the disease affects. And so, again, we'll talk about some strategies on how to, best address executive dysfunction, but I wanted to let you know what it might look like. Another type of cognitive impairment that you might see in some people with Parkinson's is memory impairment. And this is trouble learning new information or recalling recently learned information. Now, things you've done in the remote past are usually intact. So if you talk about something from 20 years ago, usually those memories are, not disrupted by this process, by the disease process. It's things that are newer. And so what might this look like in day-to-day life? Well, it could be forgetting appointments. Many times it's asking the same question repeatedly throughout the day because you've forgotten you've been told. Now this can be a little bit confounded by attentional deficits. So sometimes people just aren't paying attention. And so that can masquerade as a memory deficit, because if you didn't actually listen, it's really not a matter of remembering. It's just that you never brought the information in to your awareness. Frequently losing your keys or other items, especially if you never had a problem with things like this before. So people will say, you know, I routinely search for 15 or 20 minutes for my phone or my keys before I leave the house. This was never a problem before. That could be a sign. And then trouble learning new information. So for instance, let's say that your friend told you that you're going to meet at this restaurant, and it takes you 3 times before you can reliably find it without using a map or your GPS. That might be another subtle example of memory impairment. The other example is this slowed processing speed. This is another way that Parkinson's can affect your cognition. And so, you know, we call slowed movement bradykinesia, right? That's the slowed movement of Parkinson's. Well, that comes from the Latin brady, which means slow, and kinesia, which means movement. So in the same way, bradyphrenia, slowed thought, can sometimes happen in Parkinson's. And this can masquerade as problems in other domains, because you can imagine if you are thinking slowly, you might be more likely to forget new information because it floats off before it can be consolidated. And so again, sometimes slowed processing can masquerade as memory problems. It can masquerade as inattention, because while you're thinking about what you want to remember, the discussion moves on and you're not attending, so it can masquerade as attentional problems. You're more vulnerable to distraction for that same reason. So again, this is another way that Parkinson's pretty commonly affects cognition. And then diminished attention. You know, I put this graphic up there to just show that all of us, with or without Parkinson's, probably have diminished attention because of all the electronic gadgetry that we're distracted by, right? But in Parkinson's, this is even more concerning, because attention is sort of eroded by the disease itself. And so you really want to try to focus on one thing at a time. This is going to improve your ability to pay attention. The other thing that many people with Parkinson's notice is that attention might fluctuate with the timing of their Parkinson's medications, or the time of the day, with maybe the evening or mid-afternoon time being a little fuzzy for many people. And so in general, we tell people that if they notice this pattern with the time of day, to try to do important tasks when they're the crispest and the most attentive, and to save mundane tasks for the times when they might be fuzzy. And again, we'll talk a little bit more about strategies, but I just wanted to introduce these concepts of how mentation and cognitive function might be affected by the disease. The next thing I want to talk about is mood disturbances in Parkinson's disease. And really, I'll just go through 3 of the most common ways that we notice mood changes in Parkinson's. And the first really is anxiety. In fact, more than half of people will have significant anxiety over the course of Parkinson's disease. And about 30% or 1/3 of people with Parkinson's will have anxiety so severe that it will be considered a disorder and will require treatment. And so what types of anxiety do we see? Well, there's many different types, and I don't think it's important to know all the names for these subtypes of anxiety, but the way I usually think about it is there's anxiety that's mostly mental, where someone will worry and avoid situations because of their worry. And then there's anxiety that's more physical, that makes them tense or feel keyed up, or even have symptoms of what we call panic, which, you know, you might have rapid heart rate, palpitations. Sometimes people will even hyperventilate. And these can occur episodically, meaning people will have an attack of anxiety or panic and then it'll subside. Or it can be a constant or chronic state, which we call generalized anxiety, where people just constantly feel keyed up and on edge. Depression is another big problem in Parkinson's disease. And it's been studied now in the Parkinson's Outcome Project, which is the largest longitudinal look at which treatments produce the best health outcomes in Parkinson's. And it's largely proctored by the Parkinson Foundation, and the numbers are huge. So I think there's going to be a lot of new data and knowledge coming out of this study. And one of the things that's already become apparent is that the impact of depression on quality of life is almost twice that of the motor impairments that define the disease. And so the reason this is important is that if you're depressed, you can improve your quality of life by addressing the depression. And the good news is that with the proper treatments, depression can respond. Many cases respond with a single medication, although some people need a combination of medications to treat the depression. But depression is usually an episodic condition, meaning that it occurs, and then if it's treated, it will go away. And some people have recurrent episodes where it comes back, and other people are fortunate and they never experience a major recurrence of the depression. But again, what's important is it's probably one of the most important factors that can undermine your quality of life. So it's important to get it treated, and it can also affect your ability to function physically. We've actually shown that people who are depressed perform their daily activities with less efficiency. And so again, I really think this is something that if you're feeling depressed or low or sad, or even if you don't feel sad, and this is the case for many people, maybe as many as half of people who have depression, deny ever feeling frank sadness. But what they do notice is that they're less interested, or that they enjoy their usual activities less. And so either of these things could be an indication that you have depression and that you should seek treatment. Now, another condition that can be confused sometimes with depression is what we call apathy. And this one also occurs pretty frequently, and usually in more advanced disease. It can affect about 1/3 of people with Parkinson's at some point. And usually it's more likely to be older men, like I said, with more advanced disease and more motor symptoms and some cognitive impairment. And what people usually report with apathy isn't necessarily negative emotions. They don't necessarily have the sadness or negative thoughts that people with depression have, but they do feel unmotivated, slowed down. They don't enjoy things as much, but they're also not distressed by things that would normally be distressing as much. In fact, they're often unfazed. And so here's a sort of Venn diagram that can sort of show you the overlapping symptoms that are shared between depression and apathy, and then the things that are more exclusive to depression. So again, strong emotions in either direction, good or bad, are usually not consistent with apathy. And the reason it's important to differentiate these two syndromes is because they may have different treatments. In fact, most often they do respond to different treatments. And so sorting these out is important. Now, one of the things that can be true of all three of these mood symptoms, anxiety, depression, and apathy, is that they may have a relationship to your dopamine medications. And so typically people take their Parkinson's medications on a schedule, 3, 4, 5, 6 times per day, right, is not unusual. And you take these medications and the body absorbs them, and your movement symptoms, your motor symptoms are alleviated and get better. And for some people, their anxiety, mood, and motivation changes during the same period, so that as the movement symptoms get better, many people feel happier, many people feel less anxious, and many people feel more motivated. And unfortunately, as the medications wear off, some people experience this fluctuation between the on and off state as a return of not only their motor symptoms, but of worsening anxiety, low mood, or feelings of being unmotivated. And so I often tell people one of the first places to start when we're addressing problems with anxiety and depression and apathy is to determine whether these changes occur as a function of your medication cycle. And so usually the best way to do this is to keep a diary for a week or two. And when you notice that you're anxious or depressed or unmotivated, write down the time in relation to when you took your last dose of medication. And over the course of a week or two, you should be able to determine if this is happening during the on state or during the off state, or if it's maybe more a function of the time of day or unrelated. And that can really help, because anxiety and depression sometimes are impacted by dopamine in a large way, and other times they're mediated more by other brain chemicals like serotonin or norepinephrine. And the sooner we can figure out how this plays a role, or whether it plays a role at all, the better we can target treatment for these symptoms. And so just to show you in a more concrete way what this association looks like. In the case of mood and on-off fluctuations, there was a study done back in the 90s where they gave levodopa infusions right into the veins. And basically what they showed is that as the levodopa was administered intravenously, people's movement assessed by tapping their fingers improved. And at the same time, so did their mood. And then you can see that dark box is the time of the infusion. When the infusion is cut off, you can see that both lines, the movement line, which is represented by tapping, and the mood line, begin to decline. So both mood and movement decline in the absence of the dopamine. So this is clearly an indication that some mood is responsive to the dopamine levels. And in the same way, this was demonstrated with anxiety. In this one, though, the association is reversed. You can see that as the dopamine infusion begins, the anxiety improves, both rated by the patient and an observer. And as the infusion is stopped, the anxiety rises again. And so, if this association is there, the first thing to do is to optimize your Parkinson's medication regime before you would take any separate actions to improve anxiety or mood. And this is really an important point. So when I go about helping people with their mood or anxiety, the first thing I do is make sure that their neurologist has worked with them to optimize their Parkinson's treatment, because it can have such a big impact on their anxiety and mood. And let's say, for instance, though, that we determine that anxiety, mood, or apathy are not fluctuating with the Parkinson's medications, meaning that they sort of have a separate mechanism causing them. At that point, that's when we would probably start to introduce serotonergic medications, antidepressant medications that modulate the levels of serotonin and norepinephrine. And in the case of apathy, sometimes we use medications that help increase the amount of acetylcholine, because we think that might be one of the important chemicals causing apathy in some people. Now, what can we do, on the patient side, on the side of the people who actually have the Parkinson's? What can you do to fight? The doctors will do their best to prescribe medications that help both with your movement and your mood and Parkinson's and your cognitive changes. But what can you do actively? Well, there's been increasing interest in what we call cognitive remediation strategies or cognitive training. And by and large, these are sort of behavioral interventions that are trying to improve the way we think and problem solve in people who've experienced a decline in cognitive function. They also want to enhance or extend function even in domains that are still intact. Now, this sort of cognitive remediation and cognitive training really had its first start in post-stroke patients. People who had survived a stroke and then had some deficits, but now it's being adopted more and more to other diseases and disorders. And these interventions can be administered individually or in group formats. And I've been very heartened to see that a lot of the big and loud programs and the Rocksteady boxing programs are starting to include elements of cognitive training, doing a really good job to target the cognitive domains that are specific to Parkinson's. Some of the examples you'll hear are guided practice on cognitively demanding task, strategy use, and then there's a bunch of computerized cognitive exercises that might be helpful. Now, again, the research into this specifically for Parkinson's is still pretty new, so there's not a lot of data, but I'm going to go over some of the best evidence findings here for you. And this little model or outline, I just want to walk you through because this is sort of how the people in this research realm think about it. So there's the overarching idea of cognitive remediation, which are interventions to sort of mediate the decline in memory and other cognitive domains, in this case in Parkinson's. And then there's really, from there, 3 tiers. There's cognitive stimulation, which is sort of a less formal type of participation in activities which are generally stimulating either cognitively or socially. And these can be things like discussion groups or reminiscing, maybe by going through photo albums and remembering old times, because what this really does is just like working muscles. When you look at a picture that has a memory attached to it, it's like it's activating those neural pathways and reinforcing and strengthening them. So these things do have merit. And then discussions groups cause you to think critically to both convey and receive information. Again, so this is a type of mental exercise, just like you might work out to strengthen your muscles. You need to do things that are cognitively stimulating. Cognitive training is sort of a more operationalized and systematic approach, and it provides theoretically driven strategies and skill training and guided practice on various tasks that might reflect specific cognitive functions. So that might be a strategy-based type of cognitive training, which teaches techniques to enhance strengths or adapt to weaknesses, or it can be computerized, which really has a variety of ways to test cognitive domains and to exercise. And then some of these are adaptive, which is really neat, meaning that if you succeed at the sort of easy tasks, it ups the level of difficulty so that you keep growing. Now, with the strategy-based techniques, what's interesting is there's sort of internal strategies, which teaches you ways to manipulate information in your mind, such as chunking, using 5 to 7 data elements as one piece of information to assist in encoding, and other mnemonic techniques. And then there's external strategy-based techniques, which are things that you use to compensate outside of your brain, like writing information down, using calendars and things of that nature. Now, many of these strategies are really sophisticated and really complicated. And for the most part, people who are really interested, they do have some computerized type of programs for this, or occupational therapists. This is their world. So an occupational therapist sort of lives in this world and brings these type of training to people with disorders. Again, this is looking at those 2 types of splits. And I think this is probably important. So there's kind of more than one way to go about cognitive training, you can compensate for the task, which is sort of using a workaround. You're bypassing the deficient process. So let's say that you know, and I'm going to use stroke as an example, that you had a stroke in an area of the brain that's important for doing certain language functions, and that the stroke killed off these brain cells. So now you need to use other parts of your brain to do the same thing that the now impaired part used to do. Okay, so you're finding new ways to perform tasks. Now in Parkinson's, obviously you didn't have, you know, a stroke that killed off part of your brain, but you have a disease process that's making that part of the brain less efficient. And so what you're doing is recruiting new areas of the brain to help do the same thing, just slightly differently. And there's all sorts of sophisticated ways to go about this. And that's what we call compensatory cognitive training. So you're teaching yourself new ways to do old tasks. And then there's restorative. So this is sort of saying, hey, look, it's not completely gone. The function that I'm trying to access is not gone. And so I'm just going to work to strengthen it through the same pathways. So using the same parts of the brain, the same operation to do this. And so again, sometimes these strategies will mix workarounds with direct pathway strengthening to help people do better. And what's important is that just like physical exercise can sometimes regain lost function, we think that cognitive training can regain lost function and also prevent you from declining more quickly. And so again, I think this is a really important message. So what's the best evidence right now? Remember, I said that the research on cognitive training in Parkinson's is still fairly new, and we don't know much yet. But what we do know is that there is definitely a signal across many studies that it might help lessen cognitive decline or slow cognitive decline in Parkinson's. And specifically, there's been improvement in executive dysfunction, which is great because that's, as I mentioned, one of the most common types of cognitive change we see in Parkinson's. And this includes cognitive flexibility, planning, and processing speed, okay? Now, again, the maybe disappointing news is that so far the studies on cognitive training in Parkinson's have not shown a robust improvement in memory or visual spatial skills. Okay, now this could just be a limitation of the current research, meaning that we need more study about the ways to best support memory and visual spatial skills using cognitive training. And in that way, I would remain hopeful because in many other disorders, these skills do improve. And so it may just be a matter of finding a way to bring this to Parkinson's disease. Okay, but this is where the scientific literature is currently, okay? So again, that's cognitive training. Now what I want to do is shift to exercise. And by this, I mean physical exercise, you know, walking outside, running on a treadmill, jumping rope, riding a stationary bike, rock steady boxing, stretching, weightlifting, flexibility, all of it. These are things that are currently available. And before I forget, let me remind you that I'm going to talk about exercise today in terms of what it can do for your cognition in Parkinson's. But it's really important to remember that exercise definitely improves day-to-day functioning in Parkinson's in the physical sense, and may be disease modifying, meaning that it may slow the overall progression of the disease. And so when I mention what, you know, the next few topics about cognition and exercise in Parkinson's, I don't want you to confuse this with the known benefits of exercise in Parkinson's. So even if you don't like what I say about cognition and exercise, you still should absolutely exercise in Parkinson's because it's going to pay dividends in terms of the overall disease course and help you physically in terms of your day-to-day function. So what can exercise do for your cognition? Well, in both animal models of Parkinson's and human models of Parkinson's, it's been studied in 3 modalities. So aerobic exercise, okay, resistance training, and flexibility and mobility. Okay, so they've looked at exercise pretty globally, different types, different modalities. And just to kind of cut to the chase, I've sort of synthesized the scientific literature, brought it together across studies. And there's 18 articles in a recent meta-analysis that were thought to be of sufficient quality, meaning that they were done rigorously with good control groups. And what they found was that aerobic exercise improved attention, processing speed, reaction time, executive function more broadly, which is set shifting, organization, sequencing, and language. So I think if you remember that cognitive training, they had not shown robust benefits in language. And here we have aerobic exercise showing benefits to all of these. And remember, you can do these things in conjunction. And as I mentioned, you know, a lot of the big and loud programs in the Rocksteady boxing are starting to merge cognitive training with aerobic and other types of exercise. And so again, this is great news because this is, you know, scientifically rigorous studies have shown this benefit to cognition. And most often this is, you know, walking on a treadmill, walking, you know, in a normal fashion, riding a stationary bike. These were the most common types of aerobic exercise studied, but this does not mean that things like swimming or other things that get your heart rate up that are aerobic would not also convey the same benefit. So it's very likely, in fact, that all types of aerobic exercise would have a very similar benefit. Now, the other interesting thing is that aerobic exercise was shown to reduce the severity of depression. Resistance training, which traditionally for most of us is weightlifting, but it can be done with resistance bands, has also been studied, but there were fewer studies. And what they found was that resistance training improved executive function and attention, and that studies of resistance training show they improve balance and gait in Parkinson's. So again, even though there's been less study, there's a pretty clear signal that weight training improves cognition in Parkinson's, at least in the executive and attention domains. Flexibility. Now this, again, flexibility and mobility, which are slightly different concepts, were often included as a control group and not as often were they studied alone. And so often aerobic exercise was found to have a superior benefit, but it doesn't mean flexibility didn't. It just didn't show in the current studies. Yoga really shouldn't be confused with simple flexibility. While yoga has flexibility, it also has mobility and balance and strength. So yoga is really a multimodality exercise that is also probably very beneficial physically and mentally for Parkinson's. But at the end of the day, the research right now is just too young to show robust benefit, and we probably need more research. So it doesn't mean they don't work. It just means that they haven't been studied enough. And then I think really with the benefits of exercise fresh in our minds, this is the best time to take a break and actually try it out.
Awesome. Thank you, Dr. Pontone, for that fantastic presentation. We will welcome you back in just a short moment for Q&A. But for now, let's practice what we preach, right? And before introducing our movement break host, we do ask that you consult with your care team about concerns and recommendations before trying new exercises. And now leading us in our movement break today is Chelsea Fallstich of Age Well Senior Fitness. Chelsea is a health and wellness professional with 10+ years of experience in therapeutic exercise, functional movement patterns, balance, stretching, and preventative care through physical movement. As a registered yoga teacher with Yoga Alliance, Chelsea's goal is to provide the appropriate learning tools that will allow individuals to understand and utilize their breath to optimize their overall wellness and mobility. Chelsea, take it away, and thank you.
Hi, thank you, Melody, and thank you, Dr. Pontone. And I figured today we could take some of what Dr. Pontone just went over and apply it to some movement. So the first thing I'd like to do is really work on our breathing pattern. So really focusing on inhaling for 3 counts through the nose, and then exhaling for 3 counts. through the mouth. So think of an open-mouthed H-A-ha sound, as if you're fogging up a mirror or cleaning your glasses. And as we do that, we're going to put our hands on our knees. I always recommend that to get that added benefit of core, of strengthening and stability, to scoot forward towards the edge of your chair. Again, always making sure that you're feeling safe, secure, stable is always key and very important in any exercise that you do. So we're going to put our hands on our knees. We're going to take a nice deep inhale through the nose for 3. And as we do that, just lifting the gaze and then exhaling and rounding, pulling our stomach in, almost our belly button towards our spine, and rounding forward. And I'm going to do that from the side so you can get a better view of what that looks like. So we're going to inhale, lifting the eyes, lifting the gaze, and then exhale, rounding everything just slightly, nothing too extreme. We're going to lift the gaze. And again, if you have any cervical issues or sharp pains, always okay to just stare straight ahead, just do less. And then the same thing with rounding, we're tucking the chin. Always okay just to do less. If that movement's not available to you, always just going back to that nice deep breathing. 3 counts in through the nose, 3 counts out through the mouth. Okay. So we're going to bring our hands in front of us, palms touching, and we're going to take a nice deep inhale for 3, opening our arms up by our sides, nice and wide. And again, lifting the gaze gives a nice gentle stretch to the front of the neck. If that's too much or it's not available to you, you're welcome to keep your eyes forward. And then we're going to close our hands back together. Let's try that 3 more times. We're going to inhale, open up like we're giving a big hug. Again, lifting the gaze if that's available. And exhaling, bringing the palms together. One more time. And again, if there are any shoulder restrictions, always okay to do a little less. You don't have to lift as high or open as wide. So for our next motion, we're going to inhale. We're going to lift our right arm up, combine with our right knee, and lower it down slowly. So really engaging that core is going to be helpful. We try to avoid excessive leaning. Again, you can always use your armrest for support on the opposite side. And then we're going to alternate up and down. Nice deep inhale. Lowering, slowing. And I'm going to do it again from the side so you can see what that looks like. Inhale as we lift the left arm and the left leg. Exhale, lowering it down slowly. And again, if you notice, I'm not slouching, I'm not overarching. Again, just enough stability in that core to keep us nice and centered. And we'll do one more on the left. Okay. And last one, just to kind of bring out everything we just did, we're going to inhale, lift the arms over our head, and then we're going to exhale and take our right hand and place it to the outside of our left knee. And just gaze gently over the left shoulder. And then once more, we're going to lift up. Inhale, take our left hand, place it to the outside of our right knee, and gaze over our right shoulder. Okay, thank you so much again. I hope that helped loosen things up a little bit for you. Melody, Dr. Pontone, thank you so much. Melody, go ahead and take it away.
Awesome. Thank you, Chelsea, for getting us warmed up before Q&A. I didn't realize personally how much I needed that stretch, so thank you in advance. Now we'll welcome Dr. Pontone back to answer these excellent questions we received from our web audience today. And I want to note that because of the volume we received, I do want to acknowledge that if we don't get around to answering your question, please do consider calling our helpline at 1-800-4PD-INFO. Dr. Pontone, are you ready for these stellar questions we got?
Absolutely.
Awesome. Our first one here, let's see. As it relates to mental health, any advice on how to accept the diagnosis of Parkinson's disease?
Yeah, I actually think that's a big issue. So one of the things that we've noticed is that when people, not everyone, but when people are first diagnosed with Parkinson's, right now it still remains a clinical diagnosis. So unlike many other medical diagnoses where you can get a blood test or some sort of fancy scan and know with certainty that you have a disease, you really have to rely on the clinical impression of the doctor you're working with. And so this, to me, really leads to some people finding it easier to deny that they have this disease, because that's emotionally, denial is a normal coping mechanism when you hear something like this. And then if you have uncertainty about the diagnosis, that just makes it easier to indulge that denial. And so one of the things I always tell people is that a second opinion about the diagnosis can sometimes be helpful, because having an additional opinion can help take away some of the uncertainty in some cases and then help you accept it. Now, the other thing that we found can help many people accept the diagnosis is to join support groups or engage in educational activities about the disease, because sometimes that can be affirming as well. Maybe your disease is very mild in the beginning, which for most people it is. And so there's some uncertainty. I don't really have it. This tremor, it kind of comes and goes. Half the time I don't even have it. But as you learn more about the disease, well, you say, well, I've got that other thing too. And I've got this, and that type of affirmation can make you a little more comfortable with the idea that you have this. And, really at the end of the day, what the reason acceptance is important is that I think when you've accepted the diagnosis, you can more fully commit to fighting it.
Yeah, those are really great points. Thanks for sharing that. Another question we have here is, what do you think the impact of anxiety and depression might have on other symptoms like freezing of gait?
So that's one of my favorite topics. So thank you for that question. So I can tell you anecdotally, and certainly it's in the literature, the scientific literature as well, that one of the most common triggers of freezing is anxiety. And it's a 360-degree event, because people will tell me I get anxious and then I freeze, or I freeze and then I get really anxious. And so there's certainly a connection between those. And what we'll often do is both behaviorally and sometimes with medication, if we can alleviate the anxiety, it can actually decrease both the frequency and severity of the freezing episodes.
Great. Thank you for sharing those insights. We talked a bit about cognitive training and cognitive behavioral therapy. We have questions here. Where do you go for that? And is this covered by insurance? Yeah,
so, this is one of the things that I think I reached out to the Parkinson Foundation about, because it would be great if, as this therapeutic intervention emerges, if the foundation could sort of post some links and access portals to this type of thing. But right now, like I said, the research is still pretty new and investigational, meaning like they don't have a protocol specifically designed for Parkinson's that's in wide circulation. But what I will tell you, and especially here in the Mid-Atlantic, many of the Rocksteady boxing programs are already incorporating it as part of their curriculum, and the Big and Loud programs as well. So some of the things that you're probably already doing have this built in. And then a more formal way to get cognitive training is to, next time your neurologist gives you that referral for physical therapy, and it usually says PT, OT, SLP. Well, that occupational therapist sometimes is not included, ask for the occupational therapy referral. And those are the people that are specifically trained to administer this type of intervention.
Awesome, thank you. I think that's a great point. And we also had a question about some OT stuff here leading into, I have worked with many OTs with different patients, but they never seem to address memory or cognitive areas. What specific tasks or techniques can we ask OTs to do to work on cognitive strategies? So maybe, you know, people just aren't sure that they can ask, and what are some questions that they would bring up to their OT?
Well, so that's a great point that was just made by that question, because all these therapies, what we call the allied health professionals, PT, OT, SLP, they all need to have a specific indication. And usually that indication is a specific type of functioning. So for the physical therapist, often it's things like fall risk mitigation, right? Or help with transfers or whatever, right? So for OT, it can be something like, hey, I'm having trouble with managing my medications. I mean, think about it. You're taking medications 4, 5, 6 times a day. It could be something like I'm missing appointments, or I'm having trouble scheduling my activities, or something like that. So almost any real world function that you feel is deficient could potentially be an indication for an occupational therapy referral.
Awesome. And these questions are flying in here. We actually had a number of questions asking if you could clarify what Stroop is. It was in
yeah. So Stroop, yeah, that's funny. I forget sometimes because I've spent 20 years living in this world. But the Stroop
I have to Google it.
Yeah, the Stroop task is a really interesting set shifting task. So the color word Stroop is probably the most classic type of Stroop task. So for instance, I might show you a picture of the word red, R-E-D, in blue lettering, and then ask you to tell me what color the letters are, but you have cognitive dissonance, right? Because the word says red, but I'm asking you the color of the actual letters. And so what this causes the brain to do is to shift sets between discrimination of colors versus semantic meaning of the word. And again, really sophisticated tests that these people, psychologists and occupational therapists, that's the world they sort of live in. But we're finding that these type of activities can sometimes strengthen your mental functioning, just like we strengthen and rehabilitate muscles after injury or insult.
Yeah, perfect. I understand that much better than I did the Google answer I got. So I appreciate that. How about deep brain stimulation? Can that slow or diminish the mood disorders associated with Parkinson's and maybe even earlier on in the disease?
Yeah, so, you know, deep brain stimulation, its current primary indication is really just for the motor symptoms, right? But as everyone probably knows by this very sort of nuanced question, is that there may be unintended positive and maybe sometimes negative effect on mood. So there is maybe some signal that deep brain stimulation can improve anxiety in many people. So that's, you know, really interesting. There's been reports that it could maybe, though, worsen impulsivity too. And what I think you're going to see is that in the future, we're using more and more sophisticated technology so that some of these deep brain probes, the leads that we use to administer the stimulation, will be better able to target maybe areas that also are important for mood. And so you might get deep brain stimulation that helps your motor symptoms, but might also intentionally interact with your mood, cognition, and other symptoms.
Great. And I'm going to move on. We have a series of questions pertaining to delusions and hallucinations, which we know can be frustrating for many. Sometimes the people with Parkinson's don't seem as bothered by them as the care partner, it seems, based on these questions we're getting here. What's new in the research with treatment and coping with hallucinations and delusions? As a care partner, I'm often at a loss as to how to help my husband. Yeah,
so this is you know, probably an important point to make, is that often, not always, but often, changes like hallucinations and delusions, false thoughts, often occur in parallel and are more likely when cognitive decline is happening. So unfortunately, that makes it a little harder to have insight about what these symptoms are. So for instance, many times people can see a hallucination and be told it's not real, or internally figure out that it's not because there's incongruities between what they're seeing and what other real objects do in the environment. As cognition declines, which, like I said, makes these experiences more likely, that ability to discriminate between real and unreal, to have what we call quote unquote insight, is diminished. And so, you know, in terms of strategies, behavioral strategies, one of the things we do tell both people with Parkinson's and their caregivers is to talk about these things openly, at least between, you know, you might not want to do that in a restaurant, but, you know, at home, you certainly would want to talk about it, because that process of exploring the experience can sometimes instill insight. Now, in terms of research on the sort of more biological side, I would say that is definitely going forward, and we're learning more and more about how this is mediated. So it's probably more than one brain chemical involved. So dopamine plays a role, acetylcholine, which is the cognitive chemical that we talk about a lot, but more importantly and more recently, serotonergic pathways are probably very important. And I think that's where, you know, some of the new treatments will probably emerge from. In fact, one already is.
Great. And just to tack on to that piece, I think we have a few care partners here wondering, how do you respond to or react to some delusions, especially if they're accusatory? What's sort of the safest response? Yeah,
well, I would say the first thing you need is 2 scoops of grace, because unfortunately, often the delusions are directed at the caregiver, the person closest to the one suffering the delusion. And so, you know, spousal infidelity, or you're stealing from me, or you're poisoning me, are probably, and it's, you know, the person who's right there next to them, unfortunately, are the victims of the delusion. And so the first thing you need to do is distance yourself from that, because it's not intentional. It's a dysregulation of their, you know, mental process. And so that's what I mean by grace. You have to be able to step back and say, they don't really mean this. This is the disease talking, not the person. And then I think once you have that space, then you need to explore it a little bit. Now, this is the tricky part. So unlike hallucinations, where you can sort of explore the experience, delusions by definition are false, fixed, and you're not going to talk somebody out of these. So if you have someone with delusional beliefs that are causing trouble, the best thing to do is to move on, to change subjects and change the topic and redirect them, because usually reassurance is either ineffective or can inflame the situation. And this is definitely, delusions are a situation that you definitely want to make the doctors aware of.
Yeah, thank you. There were quite a bit of questions about that. How about, how can you get someone with Parkinson's to start exercising or do any type of activity when apathy is getting in the way?
Yeah, well, that's a great point, because apathy is by definition, the absence of initiative, right, and motivation. And ironically, though, it's usually literally initiation, just the first part. So oftentimes what we found with people who truly have apathy as opposed to depression is that if you can initiate the exercise for them, or give them enough external structure to support the activity, they'll go along with it. And that's the thing, is you just have to get them moving. So sometimes you might grab an apathetic person's hand while they're sitting on the couch and they're like, no, I don't want to. But if you forcefully lead them, right, toward the activity and engage them, they'll go along with it. Whereas someone with depression will complain the whole way, and maybe, you know, you'll be in the middle of a fight. But I would say at least give it a try, and the more structure, the better for someone with apathy.
Great, thank you. And I think we might have time for 2 more questions here. Again, I want to mention we have some of these rolling right in, and if we don't get to your question, it's very important that you do call our helpline at 1-800-4PD-INFO. We're here for you. We want to answer your questions. This next one, sort of, you touched upon this, but how can one get an assessment and a plan for both the appropriate exercise plan and cognitive training plan? My neurologist just sort of dispenses pills and says cognitive issues are normal.
Yeah, so again, when you, next time you get to the neurologist, you can ask for a referral to the allied health professions. And usually it's best when it's delivered in a package that includes the physical therapist, which can give you the exercise routine to follow, the occupational therapist that can troubleshoot specific functions or tasks that might benefit from cognitive training and other modalities of cognitive rehabilitation. And then the speech language pathologist really is the person who's going to focus on speech, language, and any swallowing difficulties, which are an emerging risk later in the disease for many people.
Great, thank you. And I think we have some questions here sort of hoping to clarify what's reasonable to expect earlier in the disease versus later. This question specifically, do you recommend neuropsychological testing early in the diagnosis? This might be our last question too.
Yeah, no, so neuropsychological testing is not required. So many people, have their whole disease experience and never have neuropsychological testing, and their life is not diminished for not having it. However, for some people and people who are thinking about advanced therapies like deep brain stimulation, neuropsychological testing can be a very valuable tool for diagnosing and assessing current cognitive function.
Awesome. Well, thank you so much, Dr. Pontone. I have to say this Q&A segment was fantastic, but it does conclude our presentation. And on behalf of the Parkinson's Foundation, I want to thank you, Dr. Pontone, and our movement break leader, Chelsea Fallstich. I also want to thank the Parkinson's Disease and Movement Disorders Center at Johns Hopkins, which is a Parkinson's Foundation Center of Excellence. And last but not least, a very special thank you to each of you for joining us today. Again, if your question was not answered, we had some really fantastic questions here. It was really hard to pick which ones to do live. Please do call our helpline at 1-800-4PD-INFO. For more information about resources, upcoming virtual events, visit our website at parkinson.org. Or for a local touch, you can visit parkinson.org/Mid-Atlantic. This program was recorded and will be archived on our YouTube channel, parkinson.org/YouTube. And our sponsors, another round of applause and thank you to Kiowa Kirin. You can learn more about today's sponsor by visiting parkinson.org/Mid-Atlantic/chapter-supporters. And then in closing, we just wanted to, again, invite you all to join us in a movement for change at Moving Day Baltimore on May 1st or Moving Day DC on May 15th. Get involved today and learn more by visiting movingdaybaltimore.org or movingdaydc.org. In the coming days, you'll all be receiving a short survey via email. We hope you'll just take a minute to complete it. We'd love to get your feedback and hear other topics that our Mid-Atlantic folks would love to learn more about. And with that, on behalf of the Parkinson's Foundation, thank you again for joining us, and we so look forward to seeing you next time. All righty, that's it, folks. Thank you, Dr. Pontone. We'll see you soon. Bye, everyone.